Hello, everyone. Thank you so much to the organizers for the opportunity to join you today at the 27th Asian Federation of Cardiology Congress. My name is Effie Andrikopoulou. I'm joining virtually from Athens, Greece, but I work at Seattle in the United States. And I am delighted to be talking to you today about tips and tricks for the diagnostic workup of patients with cryptogenic stroke using echocardiography. These are my conflicts of interest, but none of them are applicable to today's talk. Our outline will start with a brief overview of the most recent demographics related to stroke and specifically cryptogenic stroke. Then we'll go over some of the important to recognize high-risk echocardiographic features of cryptogenic stroke, and finally go over some real-life examples. First, let's answer the question, why do we care about properly diagnosing patients with cryptogenic stroke? Well, this is sadly because stroke remains the fifth leading cause of death, with close to 800,000 patients being diagnosed annually in the US, the vast majority of them, close to 90% of them, being diagnosed with ischemic stroke. The vast majority of ischemic strokes are non-lacunar strokes, and 45% of those are labeled as cryptogenic. This means that a patient is identified based on CT or MRI imaging as having a non-lacunar stroke, but after undergoing extensive workup, including echocardiography, arterial imaging with CT or MRI, heart rhythm assessment to rule out atrial fibrillation or atrial flutter, as well as some basic blood work, including lipid profile and hemoglobin A1C, we're still unable to identify a cause for their stroke. Cryptogenic strokes, in turn, are broken down into embolic strokes of undetermined source and non-embolic strokes of undetermined source, and those are about 50% of each. It's important to note here that patients with an embolic stroke of unidentified etiology, by definition, represents a cryptogenic stroke, whereas not all cryptogenic strokes are embolic in nature. Some of them can be non-embolic. Diagnostic workup of cryptogenic stroke, broadly, this is a very broad overview because this is not our focus today, but the diagnostic workup should be tailored to the patient's age on presentation, meaning young patients, younger than 45 years old, we should focus their workup on identifying congenital or hereditary etiologies for their cryptogenic stroke. The vast majority of those is going to most likely be related to a coexisting patent foramen ovale, PFO. Other possible etiologies of cryptogenic strokes in patients with who present young could be hereditary conditions like thrombophilias or hypereosinophilic syndromes, or other types of congenital heart disease that allow for shunting between the venous and arterial circulations, like the presence of an ASD, a VSD, or a patent ductus arteriosus, or other types of more complex congenital heart defects like tetralogy of Fallot. On the contrary, in patients who present with cryptogenic stroke later in life, older than 45, older than 50 years old, we do want to focus on customizing workup to look for acquired etiologies. And in the vast majority of these cases, these patients might end up being diagnosed with atrial fibrillation or atrial flutter, or with atheromatoous disease involving their aorta proximal to the stroke, or their carotid arteries, or their vertebral arteries. Last but not least, we do also want to put everything within the clinical context. We do want to make sure that we're not missing a potential case of bacterial or non-bacterial endocarditis, or a patient with known or suspected malignancy that could be either primary cardiac or primary non-cardiac, which could involve the heart as metastatic disease. And lastly, I do want to point out this disease state that's labeled atrial cardiopathy and could affect the left and or the right atrium. It's been increasingly recognized that some patients with cryptogenic stroke who are not in AFib are still at risk of recurrent strokes, and that's because of primary atrial cardiopathy. we're increasingly recognizing that there could be something intrinsically wrong with the atrial myocytes, with the structure and function of the left and right atrium, that predisposes a certain subset of patients for cryptogenic strokes. We don't know exactly how to define this disease state, atrial cardiopathy. We don't have a good definition yet. This is very, very recently recognized, and we still have to develop our criteria in terms of imaging and blood work to identify the phenotype of these patients who are at higher risk of stroke in the absence of AFib. And now to focus on echocardiography. Echocardiograms are the workhorse for the workup of patients with cryptogenic stroke. And there's a role for both transthoracic and transesophageal echo to help us understand the etiology of cryptogenic strokes. Transthoracic echocardiography is the most accurate in looking for the presence or absence of left ventricular thrombi, especially with the use of ultrasound-enhancing agents. In addition, it's the most accurate modality in helping us recognize the presence of underlying comorbidities that place the patients at higher risk for strokes and recurrent strokes, especially the presence of coronary artery disease that could be reflected by regional wall motion abnormalities. In addition, like we mentioned, in patients with suspected atrial cardiopathy, transthoracic echo can accurately help us measure the left atrial volume. And now with the development of left atrial strain, we can acquire a more sophisticated assessment of left atrial function as well. Like we talked about, when we want to rule out the presence of or absence of interatrial or interventricular shunting, we can use transthoracic echo to help us detect the presence or absence of PFOs, atrial or ventricular septal defects, and PDAs, patent ductus arteriosus. Lastly, it is the first-line imaging in patients with presumed or suspected infective endocarditis, where we want to rule out the presence of vegetations, as well as help us rule out the presence of a cardiac tumor in patients with either a known extracardiac malignancy or suspected primary cardiac malignancy or benign tumors of the heart. Transesophageal echoes, on the other hand, are the most accurate in assessing for the presence or absence of left atrial appendage thrombi or masses, since the left atrial appendage cannot be reliably visualized with transthoracic echo. In addition, because of their much higher sensitivity and spatial resolution, TEEs are the preferred imaging modality when it comes to imaging the ascending, descending aorta and the aortic arch for the presence or absence of atheromatous plaques and their characterization into complex versus simple. And we're going to talk about it later on during the presentation today. In addition, because of the higher sensitivity and spatial resolution, TEEs are the preferred method of visualizing prosthetic heart valves to look for thrombi or pannus formation associated with the prosthesis. In addition, it can help us detect even small PFOs with intermittent shunting and can help us detect smaller cardiac masses or vegetations compared to transthoracic echo. This is an example. These are two different patients on the left and right-hand side. On the left right-hand side, we have the patient who underwent 3D TEE, showing a large left atrial myxoma, seen as this large heterogeneous echo density that's based off of the interatrial septum and protrudes within the left atrial cavity. And on the right-hand side, we have a different patient with a left atrial myxoma, again shown as a large heterogeneous echo density attached to the interatrial septum and protruding, extending within the left atrial cavity. You can see that there's heterogeneous echogenicity here, known to be associated with, known to reflect the presence of a myxoma. And after we give an ultrasound enhancing agent, here is a better delineation of the size of the myxoma, its location, and its echogenicity, which is heterogeneous and reflects the presence of scattered vascularity within the myxoma. This is an example on the left-hand side of a patient with a recent acute MI of his proximal to mid left anterior descending coronary artery. We can see here that there's hypokinesis, severe hypokinesis to akinesis of the mid and apical LV segments, septum, anterolateral wall. And as we can see here, if this plays again, there's a large thrombus at the, I apologize, this is not playing for me again. But here, there's a large thrombus at the left ventricular apex, which is known to be seen in patients with large LAD acute MIs. They're known to be at risk for left ventricular apical thrombus formation. On the right-hand side, we have a patient with non-ischemic dilated cardiomyopathy and a very, very large left ventricular apical thrombus here. Contrast these patients with thrombus at the left ventricular apex to this patient. This patient, this is a still frame of a patient with hypereosinophilic syndrome. As we can see, this echo density here, this echogenic component involving the left ventricular and right ventricular cavity is a thrombus. This is extensive thrombus overlying contiguous segments of the LV cavity with a central necrotic component. And it includes both the left and the right ventricular apex contiguous along the left ventricular and right ventricular myocardium. The way to identify these patients with hypereosinophilic syndromes is that thrombi overlie normal kinetic segments and not hypo or akinetic segments like we see in patients with ischemic or non-ischemic cardiomyopathies. There could be regional akinesis or hypokinesis in these patients as well. And this could be either because of focal eosinophilic myocarditis or coronary thromboembolism. It's important to identify these patients because if we treat them timely with interferon and imatinib and anticoagulation, then thrombi can resolve. These are examples of patients with cardiac tumors. On the left-hand side is a patient with a primary cardiac angiosarcoma extending from the left atrium, as we can see here, through the mitral valve, involving the mitral valve, and into the left ventricular cavity. On the right-hand side, we have a patient with extracardiac lymphoma that has metastasized to the left ventricular to the left ventricle, and we can see this as a large echo density, irregularly shaped within the LV cavity in a TE. Okay, switching gears and talking about patent foramen ovale, which is the most frequent cause of cryptogenic strokes, especially in young patients younger than 45 years old. Foramen ovale is a normal physiologic communication between the right and the left atrium, but it can persist in adults in up to 25% of normal individuals. About 350,000 of patients with PFOs will end up experiencing cryptogenic stroke annually in the US. And this meta-analysis here shows the close correlation between PFO and the incidence of cryptogenic stroke. We now know that patients with PFOs are about 3 times the risk of experiencing stroke compared to the general population. We don't know exactly why, but the presumed mechanisms underlying the development of cryptogenic strokes in these patients include paradoxical embolism, the most frequent etiology. This is thrombus that travels from the venous to the arterial circulation through the PFO. But we do think that there could be thrombus formation within the PFO itself that can lead to a stroke, or patients with PFO could be predisposed to primary left atrial dysfunction and atrial cardiopathy, like we mentioned earlier. And patients with PFO are at higher risk for developing arrhythmias, atrial arrhythmias that can predispose to strokes. The reason why we care about PFOs as echocardiographers is because we are called to look for high-risk features of PFOs that could place the patient at risk for cryptogenic stroke and recurrence of stroke. Those features include the presence of an atrial septal aneurysm or an excessively mobile or floppy atrial septum. And this is defined as an excursion of the interatrial septum from the midline to either the right or the left side as 10 millimeters or more, or if we measure the total excursion of the interatrial septum and the maximum distance traveled between the right and the left atrium of 15 millimeters or more. Floppy septum is defined as a distance of 5 millimeters. Patients with prominent eustachian valves or Chiari networks that are 10 millimeters or more in length within the right atrium are also at higher risk of cryptogenic strokes in association with PFOs. Large PFOs, meaning those that are more than 2 millimeters in height or 10 millimeters in length, and by height we mean the distance between the septum and secundum septum, the septum primum and septum secundum, and the length reflects the maximum overlap between the septum primum and septum secundum. And if there's a sharp angle between the PFO and the IVC that's 10 degrees or less, that's another high-risk feature that predisposes for a cryptogenic stroke. Every assessment, every echocardiographic assessment of PFO is not complete until we perform a study with agitated saline at rest and with Valsalva maneuvers. I do want to point out, though, that there's no, even though we should be routinely doing agitated saline studies, bubble study, and we especially care for detecting a large right to left shunting, a lot of bubbles, more than 20 of them. There has been no consensus about the association between a positive bubble study and a high risk for PFO. Each one of these factors is assigned with a score of 1 if it's present, and the study by Nakayama and co-investigators that was published at the Journal of the American Society of Echo in 2019 showed that a score of 2 or more was associated with a high risk of cryptogenic stroke. Here we have a color Doppler example in a patient with a large PFO and a large atrial septal aneurysm. You'll see it right here. There it is. So this is a patient at high risk for cryptogenic stroke. This is another example of a patient getting an agitated saline study. They do have a large PFO. They don't have an atrial septal aneurysm, but there are a lot of microbubbles crossing from the right into the left atrium here. And this is the same patient, an example with color and without color Doppler, showing a PFO, but with very few microbubbles. Finally, I do want us to talk a little bit about assessment, echocardiographic assessment of aortic and aortic arch atheromas. Those are defined as an intimal, as echogenic thickening of the intima of the aorta or aortic arch of 2 millimeters or more. There could be some mobile components to them, and most of the times those represent thrombi. It is important to note that the morphology of atheromatous plaques is not static, it's dynamic. It can change as thrombi can form and resolve. So those mobile components and the thickening, the thickness, could change over time. There are certain high-risk features of atheromas that we do have to make sure that we look for with echo, and especially with TEE, which is the preferred modality for assessing aortic and aortic arch atheromas, given this higher sensitivity and resolution. And the high-risk features of atheromas include a protruding atheroma of 4 millimeters or more protruding into the cavity of the aorta or the aortic arch. The presence of mobile components, which the vast majority of them are thrombi, and the presence of ulcerated plaques that are 2 millimeters or more. We can grade the atheromas based on the severity of intimal thickening, as well as the presence or absence of mobile components. And the grading goes all the way from 1 with normal or minimal thickening all the way to 5 with mobile lesions. And the worse the grading, the higher the risk for cryptogenic stroke. And we're going to conclude by looking at those real-life examples of patients with atheromas. This, on the top left-hand side, is a still frame of a patient with a very, very large and atheroma at the ascending aorta. And here, this linear structure is a mobile thrombus. On the top right, we have a patient who underwent a TE and showed a large atheroma at the very, very proximal ascending aorta right here, this echo-dense mass protruding into the lumen of the ascending aorta, just distal to the ST junction. At the bottom left, we have extensive intimal thickening of the aortic arch shown in a transthoracic echo. And at the bottom right, we have 3D imaging of large atheromas at the ascending aorta shown by the white arrows here. All of these, this, and this, they're all large atheromas. This is all I have for you today. Thank you so much, and I'm glad to take questions. Thank you.